medicine resident at the University of Michigan and St. Joseph's Hospital, both in Ann Arbor. Today, on behalf of my co-investigators, I'd like to discuss our research. We investigated the impact of a new senior emergency department on ED recidivism, hospital length of stay, and hospital rate of admission. Senior emergency department is a new phenomenon. We've had an increasing number of senior emergency departments across the nation. For instance, in the Midwest, there's about 11 in the Trinity Health System. There's also some in Mount Sinai in New York. This is largely in response to a booming senior population. I know we've had a lot of talks about this, but we've also known that the geriatric population, they have a higher complexity of care, higher morbidity and mortality. They use a lot more resources. So there's a need for a dedicated center for geriatric care. So what does a senior ED have that the main ERs don't? So first of all, you need to have an age of over 65. There's certain physical features that are very helpful for the geriatric population, such as non-skid floor, better lighting, for instance, hallway rails, bigger clocks, bigger TVs. There's certain core issues that we address in the senior emergency department, such as screening for depression, screening for polypharmacy, and evaluating their social circumstances at home. Our primary hypothesis was that a new senior emergency department would be associated with decreased frequency of return visits to the emergency department, and our secondary would be that it would be associated with decreased hospital length of stay and decreased hospital admissions. We did this at St. Joe's Mercy Hospital. It's in Ann Arbor. We see about 85,000 patients per year. This was a retrospective cohort study, and from the data, we collected it from an administrative database at St. Joe's. The way we designed this study is that the senior emergency department was opened in October of 2010. And so we evaluated our patients 6 months prior to the start of the ED and 6 months after the beginning of the senior emergency department. And I called my pre-senior and my senior cohorts. We included patients that were over 65. They had a triage level of over 2, which just meant that if someone had a triage level of 1, they needed to be acutely resuscitated, and they went straight to the main emergency department where we had the main bays. Who we excluded were those who didn't meet the age criteria, those who didn't meet the triage level. There were some that had an undocumented triage level. One had a medical miracle of 130-year-old, so that was an erroneous age. And then we also excluded patients who were seen 12 months prior to the start of that particular cohort. So in total, we had about 8,154 patients. When we used all of our exclusion criteria, we weeded it down, and we had about 3,936 in the pre-senior and 3,742 in the post-senior group, which is a large number and very well balanced. Our primary outcome, what we were most interested in, was recidivism, which we defined as a time to return visit at 30 days and 180 days. And our secondary outcomes were hospital admissions and hospital length of stay. So we used a specifically designed prognostic variable, a return risk indicator, to control for the likelihood to return. The proportion of patients who return within 30 days were calculated for each of the 66 DRG categories in the pre-senior group only. Then the DRGs were then ranked by quintile based on their propensity to return. And then the rankings were applied to each patient in both cohorts depending on their DRG category. We then used a multivariate analysis. It was applied to all outcomes, and this was used to minimize for known confounders, which would be age, triage level, their insurance status, their return risk indicator. We also used a Cox proportional hazard model to evaluate difference in time to return before and after opening of the senior ED within 30 and 180 days. This is just a table of both the demographic and the clinical characteristics. I know there's a lot of numbers, but I'd just like you to see how well balanced the two groups are. When you look at the age, they're very similar. The percentage of female, the acuity level, the different insurance types. So our results, most important. It showed that despite our interventions in senior emergency department, there was no statistically significant difference for time to return in both 30 and 180 days. We did find that the risk of being admitted was lower in the senior emergency department group, and there was no significant difference for the length of stay. So our conclusion was that the new senior emergency department resulted in a decreased rate of admissions. However, we were unable to show that the interventions had any significant effect on recidivism or length of stay in the hospital. These are my references. Thank you so much for your time today, and I'd like to extend a very special thanks to my mentor, Dr. Keys.
Nicely done. Questions? Do you think by excluding people who have been in the ED within the last 12 months, you're excluding the people who are most likely to have recidivism, and therefore diluting your ability to look at an impact on recidivism?
But what we wanted to do with that is make sure that there's not a misbalance between the two groups. So I feel that that wasn't the case when we did that. Yes?
Kevin Buzz, UNC. As part of the geriatric emergency department, did it result in greater integration with follow-up clinic options for these patients?
So we didn't specifically study that in terms of our follow-up. We do have in the senior emergency department a lot more social workers involved in their care, and so they look up in terms of what the next step. But that was one of the limitations of the study, that we didn't provide follow-up, or there are different confounders that, for instance, their PCP availability. We didn't kind of go into detail on that. Yes.
So you describe a decrease in the admission rate in the senior ED. And that seems pretty important potentially.
Yes.
And so I'm wondering why you think that happened. And I'm guessing it's not the non-slip pools. And I'm wondering if so were the physicians behaving, were they the same physicians in the senior ED, and were they thinking differently or behaving differently? What's your thought on why that happened?
So I think that one of the important things is that we do involve different things in the senior emergency department. We do heavily rely on social worker, because typically in the main ER, at least from my experience, the age of the patient is directly proportional to the risk of being admitted, right? The higher the age, the more likely we're going to say, oh, this patient needs to be admitted. But if we have certain things in the senior emergency department, such as our social worker, or educating physicians as well, that we can ensure that the patient can go home, that they're 85 but they can go home, that I think was affecting our admission rate. And I do still think that the non-skid floors are important. Yes?
Length of stay, you said it didn't affect length of stay. Was that ED or hospital? Or
Hospital length of stay, that's correct.
It did not?
It did not, no. We actually have a table of our results. We were 5-minute limitations. So the median for the pre-senior length of stay was 3 days, and for the senior ED was 3 days.
What about ED length of stay?
We did not assess that. I think this is a big stepping stone for future research. Our emergency department was just opened in October 2010, so we've been having a lot of discussions on what future research, and so ED length of stay is an excellent suggestion.
And you just looked at administrative data. You didn't talk to
That's
patients,
correct.
right?
And so we had limited information about the prognostic variables, the severity of illness. So we were limited by the data that we did collect.
Got time for one more question?
Yes.
So the return risk indicator is kind of interesting, and it's stretching beyond my statistical ability a little bit, because usually when you think of a propensity score, it's the propensity to get the intervention,
yes,
not the propensity to have the outcome.
Yes.
So it's a question, and you may not have looked at this, did that, having that in your model, kind of overwhelm the effect of the geriatric ED? Because you already have this variable that predicted the propensity to have the outcome.
Yeah.
And I don't know the answer, but I would consider that.
So I did ask my statistician in terms of, we had her very heavily involved because the statistics heavy, and I asked why we didn't do a propensity score matching, because that would be maybe different than what we did. And she said we didn't have enough variables to do a proper PSM. And so that was one of the things. And we used the DRG categories because we used an administrative database. We didn't use a clinical database, so that was one of the limitations.
It might be interesting to just pull it out and see what your models look like.
Yes, thank you.
So thank you very much. Nice job. Nice job to all of our speakers. And we do need to clear the room for the next set of speakers that are coming in. I'm sure that any of the investigators would be happy to. Yes. A number of the investigators would be